Good morning. It's a pleasure to be here with you and to have the opportunity to collaborate and speak with you all over the next couple of days. My job this morning is to give you an update on what CDC efforts have been regarding cardiac arrest surveillance in 8 minutes or less, so I'll do my best. I'll talk fast and try to stay on time here. So I think for everyone's background, CDC got into the cardiac arrest business back in 2004 when we sponsored a project called CARES. You have some information in your packet about that project. And we supported that project for 8 years, and we felt that it was an important part of a growing national cardiac surveillance, cardiovascular surveillance effort that we were engaged in at CDC. So just to keep everyone focused in on what CDC's view of surveillance is, our purpose in surveillance is to monitor the public's health through timely collection, analysis, interpretation, and dissemination of programmatically relevant data. Everything we collect is collected for the purpose of using it to drive our programs and policies at CDC or through our partnerships with our state and local governments. To that end, when we funded the CARES, we were very supportive of affirming the idea of improving performance and improving outcomes. We had already established a stroke registry, which you'll hear a little bit about in a minute from Dr. Frankel. So we were very interested in the public health aspects of performance improvement and resulting outcomes. So I have the CARES mission here, which you also have in your packet, which I think really kind of encapsulates a lot of why we felt this was an important endeavor to support. So currently we spend our time in 3 main areas, trying to continue to improve surveillance, including cardiac arrest, increasing public awareness, particularly in the CPR and AED arena, and we've also been working with our state and local partners to encourage policies for public access defibrillation. So typically, those efforts are done in conjunction with our state and local grantees. I'm going to focus most of my comments this morning on the improving surveillance side of things. Many of you may know that we have 2 surveillance portals available to the public on the internet. One is called the Data Trends and Maps, and the other one is the Interactive Atlas of Heart Disease and Stroke. And we try to keep that data updated and current as much as possible. So one of the things that I was asked to talk about was recommendation 1 and what some of the challenges and what some of the concerns are with our ability to embrace that recommendation alone or in conjunction with others. One of the real issues here is twofold. One is there are other kind of emerging priorities, if you will, or political support priorities that trump, working on specific areas of surveillance like cardiac arrest or stroke or anything else. Those being most recently for CDC, Ebola, and Zika. You know that the rallying around those 2 efforts by Congress and the funding that is provided for those are considerable. Unfortunately, we do not enjoy the same amount of funding and support for, chronic disease, cardiovascular disease, and the like. We've instead been asked to focus our attention on prevention and health promotion, and in heart disease and stroke, that's been mainly around blood pressure control, cholesterol, and smoking cessation. This is CDC's surveillance strategy. I'll quickly just highlight the top 4 areas here. There's a lot of interest in accelerating standardization of health data and data exchange systems, enhancing the use of electronic health record systems, accelerating electronic lab reporting, and modernizing mortality surveillance systems. So some of the barriers that we see, reaching consensus among interested parties on reasonable, achievable goals, collecting data in an accessible, efficient, and timely or real-time manner. Dr. Frieden would prefer real-time data. Reaching compatibility or interoperability between registries and other data systems, facilitating data linkages across diverse platforms, coordinating state level, county level, and sub-county level data, addressing underrepresentation of special populations, overcoming or reducing health disparities, creating standardized, harmonized performance measures. And we wholeheartedly agree with the part of the recommendation that says that we need free, publicly accessible data for consumers, policymakers, and others. And we've added that we would like to see more data visualization maps at the state, county, and sub-county levels. So the last part of my presentation is, if I had $10 million, what would I do with it, or what would I suggest that we do with it? I think we should pursue vigorously a public-private partnership that represents the key stakeholders in this question. We should provide funding for dedicated data managers and coordinators for each state. We really need to work at standardizing and harmonizing a core set of performance and outcome measures. We need to create common technical specification and requirements for data transmission and storage. We need to leverage existing public and private data systems and registries where feasible, not start from scratch. Facilitate that free public access to the most meaningful and useful data for decision-making and accountability at the national, state, and local level. And the last thing that I did not put on here, but is something that we've all talked about before, is if in fact we're going to pursue making cardiac arrest a notifiable condition, how are we going to do that in a meaningful and a coordinated way? Is it through a CSTE, a state epidemiology route, or is it through a state legislature route? We've got to get together on that issue if you want that to happen. That's it. I made it. Yeah.
Good.
I was watching Meg. I was like, I better not.
Perfect.